Welcome to the Princeton Spine and Joint Center podcast. My name is Dr. Marco Funiciello, and I'm the co-director of the Interventional Spine Program here at Princeton Spine and Joint Center. I was joined today by Dr. Freddie Song, who is an orthopedic surgeon whose orthopedic interests include arthroscopic surgery of the shoulder and the knee, as well as knee and shoulder reconstruction. Dr. Song practices here in Princeton, New Jersey at Princeton Orthopedics. He received his Doctorate of Medicine from Jefferson Medical College and completed his surgical internship and orthopedic residency at Albert Einstein Medical Center in Philadelphia. Dr. Song completed a sports medicine fellowship at the Steadman Hawkins Clinic in the Carolinas, and he also received specialized training in knee and shoulder arthroscopy, as well as training in complex knee and shoulder reconstruction. Again, thank you for joining us, and welcome to the podcast. Welcome to the Princeton Spine and Joint Center podcast. I'm joined today with Dr. Freddie Song, and we're going to talk to you about the very interesting topic of discussion of rotator cuff tears, rotator cuff tendinopathy, and dive into the intricacies of surgical evaluation and surgical approach. So, Dr. Song, tell us, what exactly is a rotator cuff? What is its function?
So the rotator cuff is a group of four tendons that surround the shoulder. They're most important for shoulder stabilization and shoulder motion. The four tendons act kind of in concert to not only bring the ball into the socket, so the shoulder is a ball and socket joint, and they help to stabilize the ball and hold it in the socket because you need a proper fulcrum in order for you to move the shoulder. If you didn't have that fulcrum, the ball would just slide around and your motion would be not so good, and also you'd have wasted energy in a sense because you wouldn't have proper motion. So there are four tendons. They're the supraspinatus and infraspinatus, which are in the top, the subscapularis in the front, and the teres minors in the back. And they form a cuff. They're all four muscles that can convert to form a tendon, and that inserts into the humeral head, which is more of the ball portion of the ball and socket. And in concert, they help to move the shoulder and stabilize the ball and socket at the same time.
Gotcha. Now being practicing in sports medicine and spine medicine myself, I see rotator cuff injuries all the time.
Sure.
And part of my job as a sports medicine doctor is to see when it's something we can rehabilitate, something we can fix, and making a decision when we have to do a surgical assessment and possibly surgical intervention. So my question for you is, what are the most common types of rotator cuff injuries that you see, and what are the types of rotator cuff injuries that are most likely will need a surgical intervention?
Sure, a great question. The majority of shoulder injuries I see are actually non-operative because rotator cuff gets injured all the time and not necessarily torn or need surgery. A lot of times you have sprains of the shoulder or something called impingement syndrome. That's the most common thing probably you and I see in terms of patients.
I've read something like after the age of 40, just about everybody has some type of rotator cuff
I've had
degeneration.
It. You work out, I work out. I've had it myself. Impingements, just there's two bones, kind of one above and one below the rotator cuff, and if those bones pinch the tendon, especially with overhead motion and behind the back motions, that can cause pain. And patients actually think they tore something because, initially the pain is such that they can't really move fully and it hurts to move and they have weakness. So then they come in, and usually that's impingement syndrome. There are some red flags during the exam like profound weakness or even continued pain after conservative care. Usually those patients, we usually treat plus minus an injection of cortisone, which is very helpful for inflammation. And, we both use cortisone in our practice to help patients rehabilitate injuries, without surgery. And then physical therapy is quite important because if they can strengthen the muscles around, the shoulder, including the rotator cuff, regain motion, regain strength, patients can come back to their sporting activities. So, non-operative treatment of the shoulder is actually, even though I'm a surgeon, I see more non-operative shoulder injuries. But more acute traumatic type injuries in younger patients, patients we talked about before, sports, ultimate frisbee, or any sports where you're diving, landing on your shoulder, something traumatic, or a car accident where the shoulder sometimes either can dislocate or subluxate, which is moved out of the socket. If that's the history and patients come in with an extremely weak shoulder, they can't really move it, then we get a higher index of suspicion for more of a rotator cuff tear rather than just a sprain or tendinitis, and then we'll get the MRI and go ahead and proceed down the course of possible surgery, depending on what the pathology is.
So what's the most common type of rotator cuff injury you'll see that requires surgery?
Yeah, usually the supraspinatus is the tendon at the top. That's the most commonly injured, and you've seen that when you get an MRI. That's usually the one that tears.
Right, because of its location being pinched between the bones, the
pinched between bones location. It's also what's called a watershed area. So the blood supply to that particular tendon in the area where it tears off the bone is poor. So injuries don't really heal themselves that well, and attritionally they can build up. And then once it's torn, it doesn't heal that well, and that's why tears can propagate, and then may require surgery.
Right. So I may see someone that comes in with a partial thickness tear, usually non-operative type of tear. You would not that it's non-operative, you just wouldn't do surgery,
right,
because you'd do some physical therapy. If
sure,
there's inflammatory process, you might do an injection. Just training, maybe technique training, if they're a thrower or if they're playing an overhead sport. But when do you see? I mean, there's all these gradings for rotator cuff tears, but when do you typically see that? Hey, if we don't do something about this, it's just going to get worse. We need to intervene. How do you make that decision when someone comes in and you haven't looked inside yet, but you have an MRI and you have an idea what's happening?
Yeah, every patient's different, and we do try to treat every patient different. You get to know the patient, based on their age, their activity level, what they want to do and what they want to return to. The more active the patient and the higher the degree of the tear, the more likely they'll need surgery to get back to their higher level activities. Lesser active patients and a lower degree tear, usually an injection therapy is all you need. But I would tell you that if you have a full tear, meaning that the tendon's torn completely off the bone, which is different from a partial tear, then likely the more active the patient, the more likely conservative care may fail and they may need surgery. Partial tears almost exclusively, even in active patients, I try to treat initially conservatively, because if you have a partial tear, that means you have still cuff attached, and if you can get the inflammation calmed down, restore motion and strength, sometimes some of that, I would say the partial tear won't fully heal, but can scar in and kind of stop propagating, and patients can get back to their sport without the surgery and the downtime.
I remember when we met, nearly a decade ago now.
That's right.
We had a conversation about when there is a tear, a full tear with tendon retraction, where the two ends, they separate from each other or it pulls off the bone. Surgery should be done in a certain time frame. Otherwise, that tendon you won't be able to separate it from the other soft tissues. What kind of time frame are we talking about, and what should people start thinking when there is a full thickness, not full thickness, but full tear with retraction of the tendon?
So a full tear just means that the tendon pulled off the bone completely. There's no fibers attached. Retraction means that the tendon actually is pulling away from the bone. Because the tendons actually, if the bone's here, the muscle is here, and the tendon is intermediary, the tendon is what the muscle pulls the tendon back that way. It's like a spring system almost. So the question that we've been trying to answer in my field for decades. We followed patients with tears and try to ultrasound them or MRI them every year to see if the tear gets bigger, if it stays the same size, and it's quite unpredictable. We know a couple things about full tears. Once you have a full thickness tear, it usually doesn't spring forward and reattach, right? That almost never happens. In fact, the tear typically stays the same or gets bigger with time, and that's what we worry about. Because you're right, when a tear gets bigger, in our studies we know that to fix a 1 centimeter retracted tear typically does well and predictably does well. If the tear goes to 2 centimeters or 3 centimeters or even larger tears don't heal as predictably well, and functionality, you may not get the same motion and especially strength fixing a larger tear than a smaller tear. So yes, it's better to fix a small tear than a large tear. And I would definitely tell you that if you have a full tear and the patient's pretty active, you want to kind of monitor that. If they don't want surgery, that's not necessarily wrong. We can try an injection, try therapy, get them back to their activities. But we may want to monitor that patient, maybe get an MRI annually to see, because if that tear starts to get bigger, then we need to counsel the patient and say, hey, listen, if this keeps getting bigger, you may not be a good surgical candidate, meaning it might not work as well for you then as it would now. So that's definitely what we look for. The other key factor in tears, if you have a large tear, so larger tears are usually greater than 3 centimeters of retraction. That means the tear pulls back more than 3 centimeters from the bone. If you have an acute large tear, we know with all our studies that if you fix that large tear acutely, so if someone's painting their house, or I see this all the time during this time, putting up Christmas decorations, ladder, fall, and they have they can't move, their arms kind of what we call pseudo-paralytic. We get an MRI and they have a 3 or 4 centimeter tear. I'd counsel that patient. I said, listen, this is an acute, large traumatic tear. If you had surgery within the next 6 to 8 weeks, you will do predictably well. If you wait outside that time frame, that tear tends to scar in, and it's already a big gap we have to kind of close surgically, so your result will not be as good after that time frame, and the studies do support that.
When you go in to do surgery and you're looking at either partially or significantly retracted tendon, supraspinatus is very common. Maybe there's a couple tendons involved and it's more extensive. But what other things are you looking at? What other things are you looking for as you're doing the surgery that may need to be repaired? And specifically, sometimes we talk about there being bone spurs on the acromion, which could be impinging upon and causing damage to the tendons, rotator cuff tendons. There may be labral tear issues or other things. What do you find once you're in there and say, well, we got to think about this and correct this on the spot?
No, absolutely. So, I always tell my patients when we go in the shoulder, the arthroscope, which is that minimally invasive surgery that we do, it allows us to look into every nook and cranny in the shoulder. We can look in every recess. And I tell them, we're going to do, first thing we do is do like a car inspection, like a 20-point inspection. We look at every structure. We know it should be normal. We know it's not normal. And if it passes, check. If not, we'll fix it. Because, our goal is to have your first surgery be your last. We want to not leave any stone unturned and not have any reason to have pain after surgery. And you're absolutely right. When we fix rotator cuff tears, almost universally, we take out bone spurs. Because a bone spur grows down over the rotator cuff. And that, a lot of times, is responsible for that impinging or pinching. So if we take that out and create more space, that'll help the patient afterwards recover in their activities thereafter. Usually when a rotator cuff is torn, we look at the labrum. The biceps tendon, the biceps muscle right here has two attachments in the shoulder. One that's on a bone called the coracoid in the front that almost universally never tears. And the other dives deep into the shoulder joint adjacent and underneath the rotator cuff. And that tears often. And that's a big source of pain. So I would say at least 50 to 60% of the time when I fix a rotator cuff, I'm fixing the biceps tendon as well. And that's very common because if you just fix the rotator cuff and not the biceps, patients will have improvement in their function but still have some pain from that biceps tear. So, we try to take care of everything. So there's a lot of additional pathology that we treat when we go in there.
And how often are you going into a shoulder, and you would know prior from the MRI, but you're not specifically doing a rotator cuff repair, but rather repairing something else, perhaps that downsloped acromion or an osteophyte on the acromion. Basically, what we're speaking about is just a bony protuberance that is contacting the tendon when there's overhead activity. How many times are you going in more preventive? Is that a part of the scope?
I would tell you that impingement syndrome, which is what you're talking about with the bone spur kind of pinching on the rotator cuff, it's a tough problem. But typically with an injection, possibly 2 injections, and then therapy, we usually can solve that problem most of the time, maybe 80-90% of the time.
Maybe some activity modification.
Correct,
too.
absolutely.
Don't be painting the ceilings.
Right. Sometimes you kind of overdo it, right? Absolutely. So, and those times where that treatment modality does not get the patient better, and on X-ray we can see a big bone spur. You can see those spurs on X-ray. You don't necessarily need an MRI, though we do get an MRI to see other things if we're going in surgically. But if the larger the bone spur, and we do have a grading system, then the more likely that non-operative treatments may fail and they're going to continue to have pain from that spur. So in that case, we do go in and take out the spur solely. If we do that and don't have to fix the rotator cuff because it's still intact, that surgery is much quicker and the recovery is much quicker as well. So that is a surgery that we do, but that's usually more of a surgery when our method's non-operative treatment fails. So
you mentioned before about the young athlete diving out into an outstretched arm or a fall from the ladder, but it's been my experience both in practice and with referrals to orthopedic surgeons that there comes a certain point where we have to make a decision whether or not it's worth repairing a torn rotator cuff because one's activity level declines over time, but we still want to keep people really active because that's the secret to life and happiness and longevity. So, but is there a certain point where it's just not worth repairing the rotator cuff? Does it need to be repaired in all cases? The
rotator cuff surgery itself, if you go online or you talk to people who've had it, and there's a lot of emphasis put on not the surgery necessarily, but the recovery, right? It can be painful sometimes. It can be a little limiting. You're in a sling with a little bump, and usually it's 6 weeks, and usually you can't drive for 4 to 6 weeks in therapy. So it's quite an undertaking. if you're a very functional and you're a more mature patient and you have a rotator cuff tear, and if you get an injection maybe 2-3 times a year and you do a little therapy if it flares up, and you can continue your, golf, your tennis, your swimming, the activities you enjoy, I think that's more than reasonable to not have to be aggressive and fix those tears themselves, especially if the patient can do the things they want to do in a pain-free manner, treated conservatively. There are such tears as you get older that get larger, and we do see patients who come in with tears that you can't repair them. I mean that happens. If you have a tear that's small but left untreated and it retracts and gets larger, what happens is the muscle that is attached to that tendon, the tendon starts to atrophy. If you don't use the muscle, it's going to turn to fat and atrophy. Sure. Once that happens to past a certain point, we can't repair that tendon. In those cases, depending on the age of the patient, there are a couple different options. There's the option, what we talked about, is conservative care. If it hurts, come get a shot, do some therapy. Hopefully that the patients can get back to their activities for a long period of time. If it repeats, we can repeat that, not too frequently. If that does not work or is unacceptable, and the patient's more of a younger patient, maybe in their 50s, early 60s, and that does happen sometimes as well because issue is ignored, and all of a sudden you show up in our office with a big tear that can't be repaired. There's a new procedure called the superior capsular reconstruction. This has been out in the States probably for the last 5 to 8 years. A doctor in Japan actually originated the surgery about 15, 20 years ago. So in this surgery, you basically take a human cadaver skin, and it's irradiated and treated for disease, and we actually roll it up like a cigarette and slide it through our arthroscopy portal and unroll it in the shoulder, and we kind of reattach that as a roof and sew it in. So it's almost like a patch. It's called a superior capsular reconstruction, and that can hold the head down and stabilize the shoulder joint, and that's a good way to restore motion. It is not as predictable as restoring strength, but that is something that we have now where, 10, 15 years ago, if that 55-year-old patient had nothing else, then we'd have to wait until we could do kind of a more arthroplasty, which is a shoulder replacement. We don't like to do that particular shoulder replacement or reverse shoulder replacement in the younger patient. We like to wait until after 60s typically.
All right, so it sounds like that procedure really is to stabilize the joint, so that way there's not as much impingement with the bony structures.
Absolutely,
and
it's
that
an
would
intermediary.
Work.
Yeah, you're putting this
yeah.
thick patch of skin between the humeral head and the acromion, so it's kind of replacing the rotator cuff. Although it's not a dynamic structure, it doesn't move, but if it scars in and heals in there, it does keep the ball down and keeps the joint stabilized, so you can still hopefully regain motion. Yeah, absolutely.
With your classic young athlete, a baseball player, ultimate frisbee player
Sure.
who maybe had an acute injury with rotator cuff rupture, what types of young athlete? What types of recovery times are we looking at?
Yeah, I mean, there's 2 types of rotator cuff tears. We see in patients usually over the age of 45 to 50. It's more degenerative attritional. They start to have a little shoulder pain. It gets worse. We try to treat it conservatively. If it gets worse, we get an MRI. They have a rotator cuff tear. That's more of a degenerative tear. That's very rare in someone in their 20s or 30s. For those patients, their rotator cuff is pretty robust. They need some kind of more of a traumatic type of event to tear the rotator cuff, and that's what we're talking about. So when they avulse their rotator cuff off the bone, those patients almost uniformly need surgery, right? It's usually traumatic. Get the MRI. They have a good-sized cuff tear. So when you fix those patients, it's usually about a 45-minute surgery. It's outpatient, so they're in and out the same day. Yeah. A nerve block has really revolutionized this procedure. Anesthesiologists, under ultrasound guidance, can give you a little injection, and the nerve that supplies the arm, they numb this. So basically, patients don't have any pain for anywhere from 24 to 36 hours. That's why patients can go home now. 20, 30 years ago, they stayed in the hospital actually with a rotator cuff repair for a couple days.
Because of the pain is
correct. Yeah, because of the pain. Now they can go home. And once again, it's a 45-minute procedure, give or take. And when we go in there, we reattach the rotator cuff to the bone. We use plastic anchors. There's no metal involved typically. And the patient goes home. I see him the next day. And through the magic of HD TV, we have all kinds of great high-def pictures that we can share and go over. And those patients are usually in a sling with a bump here for about 4 to 6 weeks. Therapy usually starts after 2 weeks. We like to start early to get the therapist moving the joint so it doesn't get too scarred in. usually ADLs, meaning dressing, eating, feeding, using the arm to kind of take care of themselves, usually can start around 4 to 6 weeks. More cardiovascular activities such as elliptical and running, usually around 3 to 4 months. And it's a good 5 months for those patients to get back to their sport, really have their motion restored and their strength restored. So it's a stepwise progress. So
and in that athlete who's doing overhead activities, tennis, baseball,
Sure.
and so on, would you say that when would they be able to return to their sport? I know everyone's an individual, but just kind of
Sure.
rough time frames.
Yeah,
what
they
do you
can
see?
probably start doing more sport-specific training around 4.5, 5 months after surgery, and to be full bore right back in their sport. It usually takes more 6 to 8 months. To fully be back in their sport. To start training, they can do it earlier, obviously, but to work their way up.
The therapy really is starting with just some light motion. It sounds
Absolutely.
like at 2 weeks, because really they're immobilized
Right.
for 2 to 4 weeks.
Yeah. Immobilization is usually 4 to 6 weeks,
even 4 to
and
6,
then the therapist can start the mobilization because it's basically a balance. We could have everybody heal predictably if we just put them in a sling for 4 months and didn't do anything. They would heal.
Yeah.
But then they would never move their arm because they'd be so scarred in.
Yeah.
And then conversely, we could have everyone have great motion and start it right away, post-op day 1, but they would never heal. So it's kind of a balance between you want motion, not too much motion because you want everything to kind of stay where we put it and heal in. So it's a gradual progression of motion.
I always found it
protect the
interesting,
repair.
if you take a healthy shoulder and you just immobilize it
Unbelievable, right?
for 6 weeks,
Yeah.
then you will develop a frozen
Shoulder.
shoulder, adhesive capsulitis,
Absolutely.
and you will have a real rough time,
Yep.
a real rough go at getting that shoulder back. It'll be 100% eventually, but it'll take months
Absolutely.
to years.
Yeah.
So same thing.
Yeah. If you
with-
immobilize any joint, exactly.
Exactly. Yeah,
You know?
we have to keep our joints in motion, and
Correct.
and that's why we have to you have to start the early range of motion, even post-surgically, when you're
Absolutely.
trying to allow it to heal. So
Yeah.
trying to find that balance, basically.
And I do tell my patients, I said, the result of this whole process is 50-50. I have to do my job, which is restore anatomy, put everything in the right spot. And then you have to do your job, which is attend therapy, be diligent with your home program. And I always tell patients, I only work for 45 minutes to an hour. You're going to be working for 5 months, every day doing your exercises. So they have to buy in a sense, because there's a lot of investment of time in their part to get their shoulder back to where they want it. And if everyone does their job, they're usually, good thing, the results are pretty good.
So in someone who has more of that degenerative change of rotator cuff, 45 and onward, roughly, what do you see in terms of the recovery there? Is it really the same, or does it take longer, or is it shorter because they're not going back to such a high-level athletic, usually not,
Sure.
not high level?
It's usually a little longer to get their motion back and to get their strength back. A more mature athlete will take longer to get back into shape than a younger athlete. Unfortunately, that's just the way things go. But they typically, predictably do well and can get back to the activities at their same level, at the 45 to 55 level. Whereas a 25-year-old patient will get back to their activities predictably at their prior level as well. So, it's all a gradation, and, they do well as getting back to the golf, tennis, and different things they like to do. Once the rotator cuff is healed, I usually tell patients, as long as you have all your strength returned, you can get back to anything you did before, because theoretically it should be as strong. Most studies show that if a rotator cuff repair is going to fail, usually it will do so in the first 3 or 4 months.
Mm-hmm.
So if you're outside that window, full healing is typically 5 to 6 months in a normal-sized tear. When you're outside that window and they're doing great, usually you can kind of let them go and get back to their activities on a graduated basis.
So it sounds like if you've gotten the 5 months without injury,
Yeah, correct.
your statistical odds of re-tearing are not that high.
Yeah, barring another
traumatic injury,
a traumatic injury, or even if they didn't have one but they end up having one. Yes,
Right.
barring that. Yeah, if you're outside the 5 to 6 month mark and you're doing well, typically that you don't regress.
Gotcha.
Absolutely.
And usually with MRIs and the MRI imaging is the resolution on it is amazing in some cases,
Absolutely.
depending on the machine. But we can often go in knowing exactly what's happening, if there's tears in the labrum or the biceps, which you mentioned before, other tendons. But are there times when you go in, you see more, you have to repair it, like you said before, and now does this mean that the recovery time is going to be longer? Does that affect the recovery time? Are there things that you see like, okay, this is going to definitely take longer?
Yeah,
now?
that's a great question. So with the MRI, as we know, is a static test. you're laying there. I mean, I've had an MRI. You lay there. There's nothing dynamic about it.
Yeah, the less motion, the better, actually.
Yeah, exactly. Yes,
Yeah.
you don't want motion.
You don't want to move.
Yeah, absolutely. So when we go in there, our diagnostic arthroscopy is static, meaning I have a little hook probe and I pull on things, so you can actually find usually more pathology than is there on the MRI. So the labrum is tightly adhered to the glenoid, which is the socket. And the labrum is a fibrocartilaginous structure. It's a kind of a softer, spongy structure. So we pull on that everywhere, and we can find it pulls off the bone. That is a tear. It just didn't show on the MRI. So we do find things, because we do it in a dynamic fashion, that we often need to fix, that not necessarily we don't expect to, because we expect to find certain things that go along with the rotator cuff. But by and large, the rotator cuff healing trumps most other things, meaning that is the limiting factor in terms of the recovery. That if you add on top of rotator cuff repair a biceps tendon repair, a labral repair, it's usually the rotator cuff that's the limiting.
So it doesn't. It sounds like
factor.
it doesn't really extend the time it takes to heal, because
Correct.
the rotator cuff tear takes the most amount of time.
Absolutely.
basically.
Yeah. So when we talk about rotator cuff repairs, this is a very interesting. I tell my patients, and those who have been through it understand. I tell them there's a certain type of rotator cuff injury when it's a chronic tear, right? The patient's usually more mature, usually over the age of 65. They've had a tear for a long time, or they fail a surgery, it re-tears. And what happens is the rotator cuff helps keep the humeral head down. Yeah. And what happens is without that for a long period of time, I call it without the roof, the head goes up.
Yeah.
When it rides up, it can actually grind up against the bone. They're chromium. It's not supposed to touch that bone, and it hurts. Develops arthritis. That's called rotator cuff tear arthropathy. And unfortunately, if injections and therapy don't work, that's a conservative approach. Patients typically can't move that well, and they're in a lot of pain. It's a tough problem. We do what's called a reverse shoulder replacement. And a reverse shoulder replacement is a type of shoulder replacement. It's a specific kind where we actually reverse the ball and socket, hence the name. And it was developed in France in the 80s, and we started doing it in the States in around 2004. And I actually do more reverse shoulders than actual standard shoulder replacements, because we see this a lot. And when we do the surgery, it's about a 40-minute surgery. I can do it outpatient or inpatient. And the recovery for that, even though it's an incision, a 3-inch incision, that recovery, I always tell patients, is half as long and half as painful as a rotator cuff repair. Even though the rotator cuff repair is through 4 or 5 small little incisions, and it seems like a smaller surgery, for some reason tacking that tendon back down to the bone and waiting for that to heal, it hurts, and it takes a long time. With a reverse shoulder, everything's kind of put in. You just have to wait for the muscles, and the incision and the wound to heal. Right. Patients are usually in a sling for about 2 weeks, and they can start coming out and doing things on their own. Therapy starts after 3 or 4 weeks, and after about 2 or 3 months, they actually have a pretty good motion and pretty good strength. So I'm always amazed at those patients, even if it's a bigger surgery per se with, putting in metal and implants, it's actually less painful and a quicker recovery than an arthroscopic rotator cuff repair. And that's a good option for patients who have a cuff tear that can't be repaired along with arthritis and, usually the more mature patient. Yeah.
And just to be clear, it sounds like this procedure, this surgical procedure is really used for those who have rotator cuff tear degeneration, but the glenohumeral joint, the main ball and socket shoulder joint, is mostly intact, because you're still using that joint, although reversed.
Right.
You're still using that articulation, that joint connection in order to move the shoulder.
Yeah, but in fact, in this reverse shoulder, we actually do cut the head like we do in a standard shoulder replacement. Mm-hmm. So if the patient does have any arthritis, this will treat that as well.
Okay.
So it's kind of it's a 2-for-1 in a sense. Yeah.
When would you choose to do a total shoulder versus the reverse?
Question.
Yeah.
Yeah. So a total, or we call it anatomic or total shoulder replacement, is almost like the hip. The socket is diseased. It doesn't have cartilage, so we actually implant a plastic a shell. It's a polyethylene plastic. And then on the ball side, we put a metal ball, right? And that plastic and ball articulation is what your new joint is. So the arthritis that was there, the ball and socket that were bone on bone, are gone. And that's exactly what a hip is like.
Yeah, and I just want to jump in and say,
Sure.
for our listeners out there, we were talking a lot about rotator cuff tendinopathy and tears. where when we talk about shoulder replacement, really we're talking about the actual joint, the cartilaginous ball and socket joint is worn down.
Right.
And often that is accompanied with degeneration, almost invariably degeneration of the rotator cuff. But in this case, it's actually the ball and socket joint, like you said, in the hip or in the knee, where the surface has worn down. It's like
arthritis.
It's like your brake pads in your car wearing down and it's squeaking because there's no more brake pad left.
I love that analogy. That's right.
Yeah. So that needs to be changed.
Right.
And
in order to do that, the difference between a total or anatomic versus a reverse shoulder, you do in arthritis, the rotator cuff's usually intact, and if so, then you can do a standard shoulder replacement. But the rotator cuff, when you're doing a shoulder replacement, either for arthritis or for chronic rotator cuff tears and rotator cuff tear arthropathy, if the rotator cuff's not functioning, then you always do the reverse. Because you can't put a standard shoulder repliment in without a functioning rotator cuff, or it'll fail.
Yeah, you need muscles and tendons connected
to hold it together.
to control
absolutely.
that shoulder.
That's correct. So that's the great question. That's the distinguishing factor between the two.
And you mentioned before about labral tears. When I speak to patients, there's labrums in various parts of the human body. The most commonly torn ones that I see in the hip and shoulder.
Absolutely.
Interestingly, I've seen high-level athletes with labral tears who are 100% functional and completely out of pain. And I've seen other athletes and other patients who walk through the doors here, and they have real severe pain that is coming from their labral tears. So, one interesting point to bring up about labral tears is you can't always see them on MRI.
Absolutely, they're very hard to see. Yeah.
Very hard to see, and as I said, they lay against the soft tissues there and the glenohumeral joint. So you have to separate that sometimes by doing an MRI arthrogram, which simply is, as you know, an MRI where you put in some contrast into the joint. So my question for you is, how often do you utilize MRI arthrograms? Are they helpful for you? In what situations?
Yeah, typically less so in rotator cuff tears, because the MRI itself, without introducing dye, is very good at discerning whether it's a full tear or not a full tear. I would say if someone had already a rotator cuff repair, and I suspect a re-tear, their exam shows it, and I suspect something's going on, and I will add dye, because scar tissue, if you've had surgery, you definitely have scar tissue. That can kind of cloud things and make things not as easily discernible in terms of pathology. So in that case, if someone had a rotator cuff repair, or any shoulder surgery for that matter, and I suspect a re-tear of the rotator cuff, I would usually add dye to make things a little sharper to see and what's going on, make it more accurate, because the scar tissue can cloud things. That's one instance. The other instance is exactly what you said. Any labral tear I suspect, I would use dye, because the labrum is this small structure right up against the glenoid, the socket, and it's hard to see tears sometimes. So that dye, when it gets introduced via needle into the joint, it basically kind of penetrates any kind of crevice, and then it will light up in the MRI. It's much more accurate. So those are the two situations where I would use dye.
Yeah, absolutely. And just a lot of our viewers may not know what a labrum is, but the way I've always described it is you have a ball and socket joint, and the socket of the hip joint is much deeper than the socket of the shoulder joint. And there's a reason for that. We don't. Our most important tool that we have is our hands. And in order to get our hands where we need them, we need to have a very mobile shoulder joint. So you need a shallow socket, so that way you can move your shoulder around a lot. Well, that ability to have great range of motion actually does lend to the problems later in life that we get in the shoulder, the rotator cuff tears, the labral tears. But the labrum is basically a rim of soft cartilage that is around the surface of the glenohumeral joint, just to deepen the sock a little bit, but not limit the range of motion because of its soft tissue structure. But when you see these tears, do you always repair them if you're going in and finding them? How do you make that distinction whether or not a labral tear needs to be repaired or not?
Labral tears themselves for repair typically are repaired in case of instability. And that's usually a case of a younger patient who dislocates their shoulder, and then the labrum pulls off the bone, and then it leaves them susceptible because they lose that bumper effect, or that that ring, that deepening, and then they'll come out. They'll keep coming out. So in those cases, you repair the labrum. There are a lot of degenerative labral tears we see after the age of 50. It's almost, if you get an MRI of most patients over the age of 50, there likely is some kind of a degenerative labral tear. Those don't need to be fixed at all. In fact, if you do try to fix those, you might tighten up the shoulder and cause stiffness. So we don't usually fix those. the tears that we most fix in the labrum with relation to patients and rotator cuff who are usually more mature over the age of 50 are slap tears, right? A slap tear, SLAP is an acronym, superior labrum anterior to posterior. It's basically where the biceps inserts into the labrum. Well, that's a point, if there's a tear there, every time you're kind of lifting things up, that biceps is pulling on the labral tear, and that does hurt, and you've seen it, it can cause a lot of pain. So those are the labral tears that we usually address in the patient with rotator cuff tears. Yeah, less so instability types. That's a kind of a different pathology in patients who dislocate their shoulder, typically younger athlete type patients.
Right. So the difference in the athlete presenting to you would be someone who didn't dislocate, doesn't have instability, but has pain, and MRI shows clear-cut rotator cuff tear, full thickness perhaps, or retracted, and you go in expecting to do a pretty straightforward rotator cuff repair surgery versus somebody who maybe had that same traumatic injury except that their shoulder was dislocated and now they're having subluxation, having dislocation, recurrent dislocation of their shoulder.
Right.
You know you're going in, an MRI perhaps with or without contrast shows that there is a labral tear. Now you know you're going in and doing a little bit more of an extensive repair.
100%. And it's a rare case, but you're absolutely right. Yep. In a younger patient who has dislocated and does have a rotator cuff tear and a labral tear, you want to address both pathologies in that patient because that labral tear is a real labral tear in terms of instability. So you first address that because it's in the joint, and then you go over the joint and fix a rotator cuff. And even that recovery is very similar to a standard rotator cuff repair because that's kind of the longest type recovery. So it doesn't lengthen their recovery, but it is more surgery, but it needs to be done in a particular case like that. It's rare, but it does happen, absolutely.
I want to share a personal story from after one of the hurricanes. I think it was Hurricane Irene, or I don't even know what year, 2011 or 12. Yeah. One of my neighbors lost a huge, beautiful oak tree in that storm, and they were leaving all the beautiful oak wood right in the front, and I said, I can't let this go to waste. So I nearly broke our minivan taking these giant wood chunks that were probably 4 feet across, and I hand split for basically 3 weeks, a few hours a day, and I really irritated my rotator cuffs just from all the overhead repetitive emotion. But in this case, there was no tear. It was more of an inflammatory process. I did some physical therapy, some injection therapy, and it basically completely recovered. But do you see people who just do these chronic repetitive things, and eventually with that impingement, you see tears, and that become a surgical case?
Yeah, that happens, especially in a lot of these very physical manual labor jobs, pipe fitters, mechanics, electricians. They're working overhead all the time with heavy loads. Usually in their late 40s or 50s, I always see them coming in, ask them how long they've been doing it. Inevitably, it's 20 to 30 years, hardworking, and they attritionally kind of tear the rotator cuff. We see it in masons a lot, too. I treat a lot of masons, bricklayers. Very hard work. And, over time, that rotator cuff is going to fail, just like brake pads will or car tires will if you drive it long enough. And we do see that, and we have to fix those as well. And they do typically do well. It's a little harder if they go back to the same work at the same, for the same hours, and, they may have a little higher failure rate. So oftentimes it's kind of their shoulder telling them, hey, we've got to slow down a little bit here. But, those patients do have tears, and we do treat those, and inevitably they do pretty well. It's a little harder for them to go back to the same heavy type of work, depending on their age.
Sure. I've seen lots of people injure the rotator cuff. There's a couple scenarios, but one in particular I'm thinking of is someone who goes travels and then is putting their luggage in the overhead compartment, trying to jam it in there, and it seems like I've had so many patients come in with overhead luggage compartment issues causing rotator. They can't get their bag in, and they tear the rotator cuff.
Yeah, I mean, it's oftentimes it's a heavier load, and it's something that patients you're not usually doing.
They're not typically doing
so
it.
Your shoulder's not used to doing that. You take a 60, 50-pound suitcase and try to jam it in, and you're actually extending your arm, and then you're in a vulnerable position is what happens, and then you end up having an injury, and that's what we see in the office. So.
And on the flip side, I've seen someone who said they were just turning their steering wheel and heard an audible pop in their shoulder. I did an ultrasound here in the office, a full thickness tear, and it seems unbelievable, but the reality is that over time they probably had tearing without an inflammatory process. It wore down. The rope was tearing, but there was no pain.
Absolutely.
And one day it was just the last straw, and it popped.
Yeah, it's quite amazing, the presentation. Patients, they can come in with just weakness and no pain,
Right.
and they have a rotator cuff tear. You can have patients that come in who have exquisite pain. You can barely move them, it hurts so much, and they have a very similar rotator cuff tear, inevitably with more inflammation, but they can present in different ways and have history in so many different ways. So, it's our job to kind of discern, what's torn and what's not torn, I think, is the first thing. What we can treat without surgery, and we try to do that first if we can, and then what we need to treat with surgery. So, and that's the challenge in the art of medicine that we see. Yeah.
Many times with being an interventional physiatrist, sports and spine, one of the beautiful things that I can do, and you do as well, is we can put medication right where we think the problem is and see the result. I've seen plenty of patients who have shoulder pain that looks like it's a shoulder issue,
right,
but it's coming from somewhere else. Most commonly coming from the neck itself,
sure,
like what's called a cervical radiculopathy, or a pinched nerve, as people say, in the neck, which then causes pain that can extend into the shoulder. So you do a shoulder treatment. If it's image guided, you can actually see the rotator cuff there on the spot and see if there's a tear, see if there's inflammation of the bursa, do the injection, and it's usually amazing afterwards.
Right.
Like, well, doc, I can move it.
Yeah,
how did it work so quick?
Yep.
Well, it's the numbing medication.
Yeah.
We have to wait for the corticosteroid to kick in, but you usually get that instant feedback about whether or not.
That's a great diagnostic test. That's where an injection is diagnostic, right?
Yeah.
And therapeutic. The
Yeah,
lidocaine of
every
numbing
injection
medicine,
basically is diagnostic.
It's selective
and therapeutic.
injections. They really do help us figure out where the pain is, because it can be in multiple places, and that helps tremendously guide our treatment. So that's where they're very helpful.
Absolutely. Any other? I mean, we've gotten pretty far into this. Any other surgical types of interventions that you do for shoulders? Any other things that you?
In terms of the rotator cuff, I would just emphasize a couple things. The surgery itself is pretty straightforward. It's outpatient. Nerve blocks have helped tremendously, and patients predictably do well. The recovery, it is a longer recovery, and there is a little bit of pain associated with it. But if I counsel my patients, say, listen, you should use a lot of ice. We don't want to try to push a lot of narcotics. We try to kind of limit them. And if you're going into that, you have a certain mindset. It's not as bad as people think it is or make it out to be. I mean, I have plenty of patients who've had the surgery, take narcotics for maybe a day or two, less than a couple days. My goal is to try to get patients off all narcotics within a week, and we've been pretty successful with that. So I would say the fear and stigma about the recovery, the modern techniques have made it such that it's much easier and reasonable to recover from. And with a little time invested up front, you can have a shoulder that will predictably do well for a long period of time. And we keep advancing techniques and implants and things. So I think things will only get better. And I'm excited to see, what we develop in the future to treat this problem.
Very cool. The only thing I'd like to add is from a physiatry and sports medicine and ergonomic kind of viewpoint is if you have someone who's doing something in their life that's irritating the rotator cuff, often you can change that behavior.
Absolutely.
So you can. I explain to my patients, you can bring the work to a level that is more conducive to treat your shoulder well. So bring things lower. Try not to work overhead as much. Bring yourself up to the thing that you're working on, so that way you're not reaching so high. I've seen, for example, for people who lay sheetrock, I've seen them walk around on stilts so they can do the sheetrock easier, and they're right up at the ceiling.
Right.
That's just one example, but there's so many things, just little things in our lives that we can do with the mouse. Make sure the mouse is not on top of the desk. Make sure it's next to the keyboard.
Sure.
All that shoulder hiking, just micro motions,
right,
but hundreds of times a day can cause wear and tear slowly over the many years of our lives.
And unfortunately, we live in a computer world, but unfortunately for shoulders, because they do take the brunt, because everyone hunches over their computer and slouches.
Right.
That's the worst thing you can do for your shoulder in terms of posture and position, and that's so important.
I advocate those standing desks because it kind of forces you to have your arms low and in the right position.
Absolutely.
Not to mention the neck and lower back too.
Yeah. Don't forget about those, right?
Yeah, absolutely. Very cool. Well, thank you, Dr. Song,
Thanks
for joining us. And I'd like to thank our viewers for joining us.
Thank you very much.
Here today. And we encourage you to join our next podcast. Take care.